Imagine having, well, just this chronic, agonizing condition that affects literally every single aspect of your daily life.
Yeah, just constantly in the background or the foreground, really.
Exactly. And, your doctor knows exactly what the gold standard cure is. But because you're a breast cancer survivor, your oncologist looks you in the eye and tells you that taking that cure could actually trigger a recurrence of your cancer.
It's just a devastating position to be in.
It really is. I mean, you are completely out of options. You're basically told to just live with the pain, or, well, at least that used to be the case.
Right. Thankfully, things are shifting.
They are. Today, we are exploring the staggering medical reality that is, quite honestly, steeped in silence. We're looking at the fact that nearly half of all postmenopausal women, and this is a population that will exceed 1 billion worldwide by 2025, by the way, suffer from genitourinary syndrome of menopause, or GSM.
And the symptoms of GSM, I mean, they're often completely debilitating. We're talking about severe dryness, a persistent burning sensation, incredibly painful intimacy, and just recurrent, relentless urinary tract infections.
It's awful. And despite how common and agonizing this is for you or someone you know, an international survey in our research revealed that 77% of respondents felt uncomfortable even discussing these symptoms with a healthcare provider.
Yeah, that is a massive, massive portion of the population just suffering in the shadows.
So our mission in this deep dive is to explore a truly revolutionary non-hormonal treatment. We are looking at technology originally designed for, of all things, facial dermatology.
Right, highly specific lasers.
Yeah, lasers that are being used to quite literally turn back the biological clock of vaginal tissue.
We actually have a really fascinating stack of sources to go through today. The data comes from this wealth of clinical trials, comprehensive physician roundtable transcripts, and best practice consensus documents.
Yeah, and they're analyzing both fractional CO2 and erbium.YAG laser therapies, right?
Yeah, exactly. Both of those modalities.
Okay, let's unpack this. Traditionally, the established treatment for this condition has been local estrogen creams. But as we established right at the top, for a lot of people, that door is firmly locked.
It's just not an option for them.
So how on earth does shining a beam of light into the body bypass the need for hormones entirely? I mean, to understand the solution, we first have to understand the environment we are trying to fix, right?
Right. We need to look at what is actually happening at a cellular level.
Hmm.
When a person goes through menopause, there is a systemic drop in estrogen.
And estrogen is kind of the fuel, isn't it?
Yeah, it's the primary biological fuel that keeps the vaginal epithelium, which is the tissue lining the vaginal canal. It keeps it thick, elastic, and healthy. Without that fuel, the tissue undergoes this profound and rapid transformation.
It basically starves.
Exactly. The epithelium thins out dramatically, it loses its stored glycogen, and the blood flow to the entire area just decreases.
I found myself visualizing this like a kitchen sponge. Like if you have a sponge that's been sitting on the edge of the sink for a week, it completely loses its structural integrity.
Oh, that's a great way to picture it. It gets all hard and crusty.
Right. It loses its ability to retain any water at all. It becomes rigid, brittle, and highly fragile. And that is essentially the baseline state of the postmenopausal vaginal mucosa in these patients.
And what's fascinating here is that the medical field has historically just offered non-hormonal patients things like over-the-counter lubricants and moisturizers.
Which don't really fix anything, do they?
No, not at all. Those function purely as surface-level friction reducers. I mean, they might offer temporary comfort during intimacy, but they do absolutely nothing to restore the physiological architecture of that dried-out tissue.
The tissue just remains thin and vulnerable beneath it all.
Exactly. The structural breakdown is just the beginning, though. This estrogen drop triggers a dangerous cascade that affects the entire microbiome of the area.
Right. The sources mention that this lack of glycogen causes a major pH shift. And I want to break this down for anyone listening because it's so crucial. Estrogen is basically the fertilizer that grows glycogen in these cells, right?
That's a good way to put it, yeah.
So no estrogen means no glycogen.
And the glycogen loss is basically the fatal blow for the microbiome.
Yeah.
A healthy premenopausal vagina is naturally acidic, usually maintaining a pH of around 4.5 or lower.
Okay.
And that protective acidity is maintained by beneficial bacteria, specifically lactobacillus, which feeds directly on the glycogen.
So no glycogen basically starves the guard dogs of the ecosystem?
Right. The good bacteria just die off.
Wow.
Yeah. And with the lactobacillus gone, the environment loses its acidity. The pH rises, becoming more alkaline, often hitting like 5.5 or even higher.
Which is bad news.
Terrible news.
Yeah.
This alkaline shift essentially throws open the gates for pathogens. Bacteria like E. coli and Gardnerella, which thrive in less acidic environments, they just flood the area and take over.
And this biochemical domino effect is the exact mechanism behind why these patients suffer from chronic recurrent urinary tract infections.
Exactly. It is a total ecosystem collapse.
And circling back to breast cancer survivors, the sources highlight that they suffer the absolute worst from this because they are often taking anti-estrogen medications, right, like aromatase inhibitors.
Yeah, to prevent their cancer from returning.
Right, and those drugs intentionally starve the body of estrogen even more aggressively than natural menopause does.
Oh, absolutely. They get a double hit of this atrophy, leaving them with severe tissue fragility and recurring UTIs. And they have virtually no conventional tools to help them.
Which leaves the medical community searching for a way to, like, stimulate the tissue without using systemic or even localized drugs.
Exactly.
So that brings us to the core mystery of these sources. If you have a completely dried out, fragile environment and traditional medicine says add hormones, how does a high-powered beam of light step in to solve a hormonal deficiency?
Well, it relies on a principle of laser physics called selective photothermolysis.
Selective photo what?
Selective photothermolysis.
Yeah.
Basically, lasers are engineered to target specific molecules in the body, which we call chromophores.
Okay, chromophore.
Right. Different wavelengths of light are absorbed by different chromophores. Like some lasers target melanin, which is the mechanism behind laser hair removal.
For sure.
Others are tuned to target hemoglobin in red blood cells.
But the sources mention two specific lasers being used here, the CO2 laser and the erbium.YAG laser. What is their target?
Their primary chromophore is water. The CO2 laser operates at a wavelength of 10,600 nanometers, and the erbium.YAG operates at 2,940 nanometers. Both of these specific wavelengths are aggressively absorbed by water molecules.
Wait, I have to push back on this logic for a second.
Go for it.
We just established that the whole problem with this atrophic tissue is that it's completely dry, brittle, and dehydrated, like an old sponge. If you're listening to this, you're probably wondering, how does targeting water with a laser even work in a desert environment? Wouldn't laser just burn an already dry sponge to a crisp?
It's a great question, and that is the exact paradox researchers had to solve. It's why standard surgical lasers cannot be used for this.
Because they just burn it.
Exactly.
Yeah.
Despite feeling incredibly dry to the patient, the cells of the vaginal mucosa still actually contain about 77% water.
Oh, really? 77%.
Yeah. But because the tissue is so thin and fragile, the power delivery has to be meticulously engineered. We really have to differentiate between purely ablative lasers, which act like a scalpel and just vaporize everything in their path, and non-ablative or fractional lasers.
Okay, so the fractional aspect is what changes the game here.
It does. A fractional CO2 laser delivers the light in a pixelated pattern. Think of like a grid of tiny little dots.
Okay, a grid.
Right. It creates microscopic columns of thermal damage, but it leaves wide islands of completely healthy, untreated tissue in between those microscopic injuries.
Oh, I see.
Yeah, so when the laser fires, its energy is rapidly absorbed by the small amount of intra- and extracellular water that is present. This rapid heating vaporizes a tiny, precise column of tissue in just a fraction of a second, without generating overwhelming thermal necrosis or tissue death in the surrounding areas.
Meaning the laser isn't actually fixing the tissue directly, like it's not welding the cells back together or something.
No, not at all.
The laser creates these controlled micro-injuries, but the actual treatment is how the body responds to being injured.
Exactly. The laser is simply the catalyst for a biological domino effect.
Well,
When those microzones of thermal damage are created, the sudden localized heat induces what cellular biologists call the heat shock response.
right, the sources mention things called heat shock proteins acting as the primary triggers here. What exactly are those doing?
The thermal energy specifically stimulates two proteins, HSP47 and HST70. Think of these proteins as emergency cellular responders.
Like little paramedics.
Yeah. Their sudden presence acts as an alarm bell that wakes up dormant fibroblasts in the tissue. And fibroblasts are the cellular factories responsible for producing the extracellular matrix and collagen.
So the injury basically tricks the body into repairing a wound, and the fibroblasts start pumping out fresh materials.
Specifically, they begin producing type I and type 3 collagen, along with brand new elastic fibers.
Here's where it gets really interesting. If you've ever done yard work, you'll recognize this concept. It is exactly like aerating a compacted dying lawn.
Oh, I like that analogy.
Right. If your lawn is hard as a rock and the grass is dying, you don't just dump fertilizer on the surface. You rent an aerator and you punch thousands of tiny holes deep into the soil.
And that stresses the grass.
Exactly. That minor, highly controlled physical stress breaks up the compaction, allows air in, and forces the root system to panic and grow back significantly thicker, deeper, and healthier. The fractional laser is basically aerating the vaginal mucosa.
And extending that analogy, the profound realization in these clinical trials is that the laser is not artificially plumping the tissue with, like, a foreign filler.
Right, it's all natural.
Yes, it triggers what researchers call thermal reperfusion. The Latin root there essentially means blood flowing again. New microscopic blood vessels sprout up to feed the area, bringing oxygen and nutrients back to the surface.
Wow.
The clinical term for it is neocollagenesis. The body is utilizing its own biological mechanisms to trick the tissue into acting like it did before menopause.
And as that lawn grows back, as the tissue rebuilds, thickens, and regains its elasticity, we see the return of our old friend, glycogen.
We do. As the newly generated epithelial cells mature, they become rich in glycogen once more. These cells naturally shed into the vaginal canal.
And there's the food.
Exactly. That shed glycogen provides the exact food source required for the lactobacillus bacteria to return, repopulate, and thrive.
The guard dogs come back.
They do. Clinical studies show that after this cellular regeneration cycle, the vaginal pH drops from that unhealthy, infection-prone 5.5 back down to an acidic, protective 4.5 or even lower.
That's incredible.
By physically rebuilding the tissue architecture, you eliminate the alkaline environment that pathogens like E. coli require to survive. The chronic urinary tract infections just stop.
It is a brilliant collision of physics and biology. I mean, you start with light, move into localized thermal trauma, trigger protein synthesis, rebuild the physical architecture, restore the chemical acidity, and ultimately reboot the entire microbiome.
It's elegant, really.
But this brings us to a really practical, urgent question for anyone considering this. If this laser is so incredibly powerful that it reorganizes cellular structures, doctors can't just blindly blast a delicate area with a high-powered beam. If you are firing a laser inside the body, how do doctors prevent causing severe burns?
This is where the physics really meets physician training. The providers manipulate three main parameters on the device: power, measured in watts; dot density, which is the spacing between the laser pulses; and dwell time.
Let's talk about dot density first, because the sources really emphasize keeping that strictly between 10% and 15%.
Right. That means only 10 to 15% of the tissue surface is actually hit by the laser energy.
Leaving the rest alone.
Exactly. The remaining 85 to 90% of the tissue is left completely intact to facilitate rapid healing. This specific ratio provides exactly enough stress to trigger the heat shock response without overwhelming the mucosa's capacity to recover.
And what about dwell time?
Dwell time is arguably the most critical safety parameter. It measures how long the laser stays on a specific microspot down to the microsecond.
A microsecond? That is so fast.
It has to be. If the laser lingers even a fraction of a millisecond too long, the heat doesn't just vaporize the water in the target cell. It conducts outward into the surrounding healthy tissue, causing a widespread thermal burn.
Yay.
Yeah, so by keeping the dwell time incredibly short, the energy is delivered and dissipates before the surrounding tissue can overheat.
There is also a major focus in these clinical transcripts on adjusting for patient anatomy and the severity of the condition. For instance, what happens if a patient has severe grade 3 vaginal atrophy?
Oh, that is a critical scenario. In severe grade 3 atrophy, the mucosa is paper thin. I mean, it has almost no structural integrity.
So you can't just use the normal settings.
Not at all. If a doctor uses standard power settings on tissue that thin, there is a real risk of mucosal perforation.
Wait, perforation, like punching a hole entirely through the vaginal wall.
Exactly. And that risks damaging adjacent structures like the bladder or the rectum. It's a huge danger.
So what safety adjustments in laser fluence, which is measured in joules per square centimeter, right, are necessary to prevent that mucosal perforation in severe grade 3 vaginal atrophy?
They have to heavily adjust that fluence. For severe atrophy, doctors will significantly dial down the power. They'll lower the wattage and drastically reduce the dwell time to create a much, much shallower ablation crater.
So they're just barely scratching the surface, comparatively.
Right. They deliver just enough fluence to trigger the superficial fibroblasts without risking deep penetration. Then, as the tissue naturally thickens after that first session, they can safely increase the fluence in subsequent treatments.
The anatomical tuning goes even further than that, too. The deep vaginal canal is a completely different landscape than the entrance, the introitus.
Very different. The deep canal doesn't have many nerve endings, so doctors can use a higher fluence there for deep tissue remodeling.
But as they withdraw the laser probe toward the entrance, the anatomy changes drastically. That outer area is densely packed with nerve endings.
Right, and if a provider maintains the internal power level as they treat the entrance, the patient will experience immediate, significant pain. They must manually dial down the power and adjust the spacing before treating the highly innervated outside areas.
But, if I'm playing devil's advocate here, how do the researchers running these clinical trials know the doctors actually fix the tissue? Like, if a patient reports feeling better, how do we know they haven't just experienced a really expensive placebo effect? You can't exactly give someone a sugar pill for a laser procedure.
Well, actually, you kind of can. In the most rigorous randomized controlled trials, researchers use what is called a sham laser treatment to account for the placebo effect.
How does a sham laser trial even work?
It's clever. The patient goes through the exact same clinical preparation. The laser probe is inserted, and the machine makes all the usual operational beeping sounds.
So they think it's happening.
Exactly. But the device is secretly configured to emit zero optical energy. No light actually hits the tissue. The researchers then compare the outcomes of the active laser group against the sham group using objective physical measurements.
And the primary measurement the sources cite is the Vaginal Health Index, or VHI. What exactly is a doctor looking for when they calculate a VHI score?
The VHI scores the tissue objectively on 5 physical parameters: elasticity, fluid volume, pH level, epithelial integrity, and moisture. A physician physically examines the tissue and grades each category.
And the results?
The clinical data shows that while the sham group sees no physiological change, the active treatment group shows highly significant, objectively measured improvements in VHI scores.
So it's not just in their heads.
Not at all. The tissue visibly changes color from pale to a healthy pink, measurable elasticity returns, and the pH drop can literally be verified on a testing strip.
They also pair that physical exam with the Female Sexual Function Index, which is a validated questionnaire tracking improvements in pain, arousal, and lubrication. And the data across the board is just incredibly positive.
It really is.
Which brings us to what this looks like in reality for the patient. The standard protocol outlined in these consensus documents involves 3 sessions, spaced about 4 to 6 weeks apart. And it's an outpatient procedure that takes just a few minutes, right?
Yes.
Yes.
And remarkably, the internal treatment is generally very well tolerated without any systemic anesthesia. For the sensitive outer areas, doctors usually apply a topical numbing cream beforehand, but the patient walks out under their own power immediately afterward.
The real-world results reported in the physician roundtables are just stunning. They are reporting up to 95% patient satisfaction. You have quotes in these transcripts from patients calling the procedure an absolute godsend.
Yeah, we're reading accounts from women saying this therapy literally saved their relationships by alleviating the severe dyspareunia, the intense pain during sex that had completely halted their intimate lives for years.
The relief from chronic cystitis and urinary urgency is equally life-changing. I mean, to go from enduring constant, painful bladder infections to normal function without the use of daily antibiotics or contraindicated hormones, that represents a monumental paradigm shift in patient care.
It really does.
But it is not all sunshine and perfect results. We have to address the major controversy in our sources. In 2018, the FDA issued a rather stark warning against the use of energy-based devices for what they termed vaginal rejuvenation.
Right, that caused quite a stir.
Yeah. The FDA noted potential risks of burns, scarring, and persistent pain. If I am a patient listening to this and I hear FDA warning for burns, I am immediately hitting pause and canceling my appointment. Where is the disconnect between this glowing clinical data and a federal safety warning?
This raises an important question about how medical innovations are regulated versus how they are marketed. The FDA's warning was largely a reaction to aggressive, sometimes irresponsible marketing by certain medical spas and clinics.
Ah, so not hospitals.
Right. These businesses were promoting vague cosmetic rejuvenation or aesthetic enhancements using devices and settings that had not been rigorously tested for those specific aesthetic purposes.
So the FDA was stepping in to regulate the wild west of cosmetic marketing, not necessarily to ban the technology outright for medical use. But how did the clinical researchers, the ones actually treating GSM, respond to that warning?
The response from the clinical community, including the UGA Working Group on Laser, has been heavily data-driven. When they analyzed the randomized controlled trials, specifically treating documented genitourinary syndrome of menopause using established protocols, they report zero serious adverse events.
Zero. That's huge. The side effects reported in the actual medical trials were just mild, temporary irritation, maybe some redness, or slight swelling that resolved entirely on its own within 2 to 3 days.
Exactly. The medical consensus emphasizes a critical boundary. When these specific devices are used by properly trained medical professionals, utilizing well-established anatomy-specific settings like adjusting that fluence for grade 3 atrophy we talked about to treat a documented medical syndrome, the data heavily supports both their safety and their efficacy.
It really highlights the vast difference between an engineered medical therapy and a glossy aesthetic marketing campaign.
It absolutely does.
So what does this all mean for you, the listener? It means you have to separate the spa brochure promising magical rejuvenation from the rigorously peer-reviewed clinical trial that is measuring epithelial glycogen, adjusting microscopic dwell times, and tracking heat shock proteins. Precision in language and diagnosis is just as important as the precision of the laser itself.
Right. Understanding the underlying mechanism is what empowers a patient to make an informed decision alongside their doctor.
As we wrap up this deep dive, let's take a moment to reflect on the sheer scale of the journey we've taken today. We started by exploring the hidden, painful reality of estrogen depletion that affects hundreds of millions of people worldwide.
A truly massive issue.
We looked at a dried-out, fragile environment that invited chronic bacterial infections, caused severe daily pain, and left cancer survivors feeling completely abandoned by modern medicine.
And we explored how the physics of light, when engineered to exact nanometer specifications and controlled in fractions of a second, can deliver microscopic injuries that serve as a biological wake-up call.
Aerating the lawn. Using fractional lasers to trigger heat shock proteins, rebuild collagen, stimulate fresh blood flow, restore glycogen, and ultimately reboot the entire microbiome of the tissue.
And all of this is achieved without a single drop of systemic hormones.
It is a brilliant, life-changing application of technology.
It really is. And as we conclude, I would like to leave you with a final thought to mull over. If we can use fractional lasers and selective photothermolysis to successfully trick aging, atrophic vaginal tissue into regenerating its own collagen, restoring its protective microbiome, and essentially acting decades younger without systemic drugs,
Yeah.
what other aging mucosal or connective tissues in the human body could we eventually aerate and restore with this exact same technology?
Oh, wow. That is an incredible question to ponder. Could this controlled micro-injury be the future of treating other mucosal disorders or degenerative tissue diseases? I guess only time and more rigorous clinical trials will tell. Thank you so much for joining us on this deep dive. Keep questioning the consensus, keep exploring the science, and we will catch you next time.